My name's Meaghan. I'm the current fellow at the Banff Sports Medicine Clinic, and I've been there since last August, and then I'll be finishing there at the end of July. And I was asked to give a little bit of a talk regarding the management of sports injuries of the knee in youth. And so there's really two areas that I'm going to focus on today, and the first is ACLs and the second is patellar instability. They're two really big areas that we see a ton of, and so I figured that that would be a bit more of an interesting topic to review. It might be something that you guys are all also very acquainted with. So if I am covering stuff that is too basic for you, or if you have questions, please feel free to interject at any time. I'm very happy to answer questions, and I don't mind being interrupted whatsoever. Just a disclaimer, this talk was made for a combination of patients and physios. So I don't know how many patients are on here. Is there anybody out there that has had an ACL tear and is getting surgery soon, or just someone who doesn't have a medical background? I just want to make sure that I am still speaking to different levels. Okay, I'm going to take that as a no. So like I said, if this is too basic or if you guys have extra questions, please feel free to join at any time and I'd be happy to answer questions. So I just thought I would start with a couple quick scenarios just to kind of get you in the idea of what we're going to be talking about. So the first one is Jamie. She was playing soccer and she made a quick cut and then felt a pop in her knee. It swelled immediately and she was helped off the field. So this might be something that you guys have heard in your clinic before. It's certainly something that we hear quite often. And then a similar story would be something like, John was playing basketball, went up for a layup, and when he landed, he felt his knee give way. There was no pop per se, but he was not able to walk and had to have help to get off the court. Or then even something similar like this, which is maybe a little bit more subtle, or not, it depends on how the patient explains it, but Katie was in a dance class and doing a new move when she felt her kneecap move out of place. In this situation, she had to go to the emergency department to get it reduced, but in other situations, they just feel some instability in that kneecap, but never actually get to have a reduction. So those are just a quick couple really quick stories that we get in clinic, or histories that we get in clinic, that help us try to decide what the diagnosis is that the patient has. So like I was saying, the main two things that I'm going to talk about today are ACL tears and patellar instability. I figure we'll start off with ACLs. I know that they're maybe a little bit more common for people. And like I said, I'm happy to kind of answer any questions that people might have. So I thought I'd start off with just a little bit of epidemiology. And I mean, first off, I think you all know this, but knee injuries are super common in the youth. In fact, they can have an incidence of anywhere between 10 to 25% when you're looking at all sports and all types of knee injuries. So about 1 in 4 athletes will have some type of a knee injury during their career. Then if we look at just ACLs, football is the highest, the sport with the highest incidence of ACL tears for boys, whereas soccer has the highest incidence of ACL tears for girls. And you can see by these numbers that soccer actually has a higher incidence than football does. So girls are actually more commonly injuring their ACL than boys are. And so then I thought I would just go over some quick anatomy, and I'm sure you guys all know this, but the ACL is the ligament that I've highlighted in yellow here. And just to give you perspective, so hope you can see my mouse, but this is the femur, this is our patella or our kneecap, this is our tibia, our fibula, these are our collateral ligaments on the side, and then these are the menisci inside the knee. This little ligament back here is our PCL. So the ACL is a ligament that helps to prevent anterior translation of the tibia on the femur, and it originates on the anterior aspect of the tibia and then goes and inserts on the medial aspect of the lateral femoral condyle. So basically on the wall of that lateral femoral condyle is where it inserts. And we do everything we can to try to reconstruct that anatomy when we're doing our ACL reconstructions.
Oh, Meaghan, just a quick, we do have a couple of coaches on board as well, just so you know.
Okay, awesome. That's great.
Yeah,
absolutely. That sounds great. And then, so these are some arthroscopic views. So this is what we actually see when we're reconstructing the knee or when we're just doing a scope. So on the left-hand side here, you got to imagine that we're looking at the notch of the knee. So if I were to go back to the previous one, this is the notch. So you have your lateral femoral condyle and your medial femoral condyle, and the ACL again sits in the middle. So imagine that that's what we're looking at. It's a bit of a limited view. This would be the medial side of the knee, and this would be the lateral side. And this would be a nice, healthy ACL. So you see that it's nice and shiny. There's no tearing of it, and it's actually quite a robust ligament. It actually fills quite a bit of the notch. And so this is what a normal ACL would look like. In contrast, you look over here on the right side, and nothing looks continuous. There's no nice white fibers. It's not shiny, and it's pretty torn up. So I would say that this is not what it usually looks like, but it's definitely possible for it to look like this. One of the more common ways that the ACL actually tears is that it tears off the femoral insertion. So back here on the femur, it actually tears off the whole thing, and it can scar down in different places. And even if it does scar down, there's times that it provides some stability, but often it's still an unstable knee because it's not where it should be. So it's not giving it the full stability that it should be giving us. And that's when patients start to run into problems and require an ACL reconstruction. So, when patients come into the office, we obviously start with our history, and some of the reasons why we're wanting that history is to make sure that the mechanism of injury, so the way that they injured their knee, fits with what we think would be their diagnosis. So when it comes to ACL tears, there's different ways that it can happen. And I think, one of the more common ones that people hear about is some type of pivoting mechanism. But it kind of happens in different ways. And so one of them is having a sudden slowdown with a change of direction. So like in a cutting type sport, so anything from soccer, football, even ultimate, you can get those type of injuries. And then there's the typical pivoting with your foot planted. Landing awkwardly from a jump. So if we think back to the basketball player that I was talking about at the beginning of it, he landed awkwardly. And what that usually means is they land into a valgus type of position. So their knee goes inwards and they collapse a little bit at the hip. And that allows for that ACL to get injured. Another one is stopping suddenly, and we saw a lot of these with the I guess it's the older turf that they were using for soccer and football, but the cleat would get stuck in the turf and then lead to that sudden stop with the possible injury to the ACL. The last one is a little bit less common, but receiving a direct blow to the knee or having a collision is definitely another way of having it, but I would say by far and large, the main way that we do see these ACLs being torn is through some type of pivoting mechanism or landing awkwardly from a jump. Skiing is a slightly different one. It tends to be of a bit of a lower energy, but I would say that that's the one that fits in more with a sudden slowdown with a change of direction. People often talk about their foot getting stuck in heavy snow and their body going one way and their knee going the other. And so again, that fits into that typical mechanism that we're looking for. In terms of symptoms, it really depends on if we're talking acute versus more chronic. But in the initial phase, some of the questions that we'll ask the patients about is, did they feel a pop and did they have immediate swelling? The pop does not happen in all cases. I'd say, maybe about 70% of patients felt a pop or heard a pop, and the rest of them don't. And then in terms of swelling, again, it's not universal, but the main reason that you're having that large swelling so acutely is because the ACL is such a vascular structure. And so when you tear it, it releases a bunch of blood and causes that big hemarthrosis in the knee that you see as swelling, or that we see as swelling when they come into clinic. I would say that the physios that are on right now, you guys, or even the coaches, you guys see that hemarthrosis way sooner than we do. And you probably see it bigger than we do too. Other things is, inability to weight bear. It's not uncommon for patients to say that they went to the emergency department on the same day to get x-rays and we're told, you don't have a fracture, but it's to that extent where they felt that pop, they had a ton of swelling and that people are worried that they fractured something in their knee. Pain definitely happens. Not necessarily because of the ACL, but I think because of a lot of the swelling and hemarthrosis that happens. But pain later on does give us clues to other structures. And that makes me come to the next point of, what are the symptoms during recovery? If people are telling me that they're having ongoing pain, I always want to know where that pain is. Is it medial or is it lateral joint line? Because then I'm starting to think about a meniscus. ACLs by themselves, once they've recovered from that initial hemarthrosis, are actually not painful. They notice instability, and that's the biggest complaint that they tend to have. But if they're also having pain, then I'm wondering, is there a chondral injury? So has the cartilage been damaged, or do they have some type of meniscus? The other thing that we're always looking for, because this really dictates when we can operate, is how much stiffness they have. If a patient comes in and they're not able to get their knee straight, they only have 90 degrees of flexion, that's not a patient that we can operate on. If we were to operate on them, we would just make them worse and really give them no benefit, because the chance of arthrofibrosis, or what would otherwise be known as a lot of scarring in the knee, is much higher in a patient who's stiff preoperatively compared to someone who's got full range of motion, does not have an angry knee, and everything has settled down nicely. And so it's better to wait for the patient to get back to moving before operating on them. And then in terms of initial treatment, so for the coaches out there, you guys know this really well. The very first thing, obviously, is our RICE principle. So rest, ice, compression, and elevation. And that's something you can start as soon as the injury happens, as soon as they come off the court or off the field. Starting that icing process will definitely help with pain and swelling. From there, our physios, you guys are awesome at this, and you really help regain that motion and get the patient to trust that they can move their knee and that they're not going to do any further damage. So regaining that motion and getting that quads activation is super important. After surgery, the quads goes to sleep, as you all know, but it also goes to sleep after an injury. Having pain in the knee by itself can make that quads not want to activate. And so working with the physios, learning how to reactivate that quads, even when you're not able to do full range of motion, is super important and very valuable. The stronger that quad muscle is and the more active it is before surgery, the easier it is post-operatively. And then definitely at some point, if the physio diagnoses it or the family doctor diagnoses that there is an ACL tear, they'll get a referral to a sports med doc, or sometimes they go to the acute knee clinic, whatever works easiest for the patient. And then if they do feel that there's an ACL tear, they usually get referred to us at that point. There are times that an MRI is ordered. It's not absolutely necessary, but if there's any concern for what we call a bucket tear of the meniscus, so a type of meniscus tear where part of it has actually flipped and is blocking some type of extension of the knee, or if it's causing the knee to lock, or if we think that there's other injuries going on that need to be diagnosed before surgery, then we will order an MRI. If we think that there is just an ACL tear and possibly a meniscus tear, we do not routinely order the MRI because we feel that we can make that diagnosis through physical exam. But sometimes they show up with an MRI and we're happy to look at them. So then in terms of diagnosis, just like anything, it starts with your history and your physical. And I'm not going to belabor going over all the history and physical components, but like I was talking about before, the history, the most important stuff is really asking about that mechanism of injury. And obviously, when we're asking the patient, we just want to know how it happened. And it can be in their own words, but we're looking for those mechanisms that we talked about earlier to see that things are fitting properly with what we think the diagnosis might be. In terms of the physical exam, again, it's your general approach to any type of physical exam, looking for swelling, range of motion, and tenderness, and then using our more special tests, so things like the Lockman, which is looking at anterior translation of the tibia on the femur. So increased anterior posterior laxity is what we're looking for, because that's what that ACL prevents. And then looking at something called the pivot shift. And this is kind of a hard exam to learn, to be honest. I think the best place to learn it is in the operating room when the patient is fully relaxed, because when you have someone who's had a knee injury, that pivot shift reconstructs the feeling that they had when they tore their ACL, and it's not comfortable. And it's sometimes easier to get it done once they've never had someone do it before, but once multiple people have done that pivot shift on them, they know what's coming and they don't like it. So it, again, can definitely be hard sometimes to get the patient to fully relax before doing it. The other thing with the pivot shift is you can't do it if the patient can't get their knee fully extended. The knee has to be subluxed initially when it's in full extension, and then it reduces as we get into that 20 to 30 degree of flexion as the IT band pulls on the tibia and reduces the tibia backwards. But if the knee cannot fully extend, then you're not going to be able to get that pivot shift, that clunk that you're looking for. The other time that you can't always get a pivot shift is when the MCL is torn, because you need to have that to be able to sort of lever offer, if you will. Other things that we're always looking for are other injuries. And so that can include your MCL, so the medial collateral ligament on the inside of the knee, or your lateral collateral ligament on the outside. So those are done, as you know, with varus and valgus stress. We're also looking that there isn't a PCL injury. So when we have anterior posterior laxity, that can be coming from lots of different places, or at least a couple different places, and one of them is your PCL. So is the tibia truly coming forward, or is it falling backwards? And we need to figure that out before we can make our diagnosis. And then the other thing is looking for those meniscus tears. With an acute ACL, your lateral meniscus is more commonly to be injured, whereas in your more chronic cases, so in patients who, excuse me, may have had a tear a couple months ago, they tried to go back to sport, it wasn't diagnosed, and they had a couple more instability episodes, well, then we're worried about having a medial meniscus tear. And then the last thing to never forget, and Dr. Heemstra always reminds me of this, but don't ever forget to look for patellar instability, because sometimes they have both. And the last thing you want to do is miss one of them. So then when it comes down to treatment, so once you've seen the patient, you've done your physical exam, you think that they're ready for ACL reconstruction, i.e. they have at least 0 to 120 degrees of range of motion, they don't have a ton of swelling, and they're ready for surgery. There's different options. And when it comes to kids, I would say that we most often just recommend ACL surgery. The reason for that is most of these patients are sports athletes, they want to go back to sport, and their chance of injuring something later on down the road without getting a reconstruction are very high. And so your chance of tearing that meniscus in the future, ending up with worse chondral injuries, they're really true possibilities for these patients. And so you want to stabilize that knee. Having that stability is what prevents those meniscal and chondral injuries in the future. And then we have to decide what type of graft we're going to use. And so when it comes to the youth, there's really 3 main ones. You could always include an allograft in this. So allograft is from a cadaver tissue, but in the younger patients, we really try to stay away from that because the risk of re-injury or re-rupture is much higher. So we tend to stick with what we call autograft, which means that you're taking from the patient themselves for this younger population. The 3 types of graft that we tend to use are first hamstring. So hamstring would be you're taking either 1 or 2 of your hamstring tendons, which comes off actually the front of the tibia. I know the hamstring is a posterior structure, and everyone seems to be very surprised that they actually insert anteriorly, but that's where we harvest them from. If they have a big enough tendon of what we call the semitendinosus, sometimes we can just take 1 tendon, which is great. But if it's not big enough, and usually in youth they're not quite large enough, you got to take the second tendon, which is your gracilis one. And then we reconstruct your ACL with that. And you can see on the picture on the right-hand side here, this is most likely a hamstring graft. And this is what it looks like when it goes into the knee. So you see a nice shiny graft, and it's going back up to that femoral attachment that we talked about before, and it starts in that tibial origin down here in the front of the knee. In Banff, hamstrings are definitely the more common graft that we use, but patellar tendons are also very common, and in some places in the rest of the world, patellar tendons are actually more common. So it's a bit of dealer's choice, but when we think about graft options, it honestly depends a lot on the patient, what type of sport they're playing, and how stretchy they are. So the more stretchy you are, the more we lean towards a patellar tendon or a quads graft. They're just a little bit more of a rigid graft, whereas the hamstring graft tends to have a little bit more ability to stretch out, especially in stretchy patients. And so if we can steer away from that in a more stretchy patient, we will. The hardest part with youth is if they're not fully grown. So sometimes our patients are still what we call skeletally immature, which means their growth plates are still open. And when we do our ACL reconstructions, we have to drill tunnels in both the tibia and the femur, and they cross the growth plates. And so the last thing you want to do is put a piece of bone, which comes with our patellar tendons and our quad grafts, across the physis or the growth plate, because that will actually make the growth plate stop growing, which is obviously the last thing we want to do in a growing kid. So in those situations, when they do have open growth plates, we tend to use hamstring. And the other option is to use an all soft tissue quads. So the quads tendon can come with either a little piece of patellar bone or not. We can just take the quads. And so sometimes we'll do that as well. So those are the three main graft options, and trying to decide which graft to use, again, is a little bit of surgeon's choice, but certainly there's we really take in a lot of factors of the patient to be able to make the best decision for that patient. And then in terms of treatment as well, we're always looking at for meniscus tears, and when it comes to these youth, the first thing we want to do is fix them. The only time we don't fix them is when they're really, really small tears in what we call the white on white zone, which just means that it's in a non-vascular area. So an area that is not going to heal very well because there's no blood supply. In those times, then we will opt to take out the little bit of meniscus, but otherwise we'll do everything we can to fix them. And then in terms of rehab, so the physios on here know this probably even better than I do, because you guys are the ones working with the patients, bringing them through all this. But generally, it's about a 1-year project that patients are embarking on. It's not to say that people are back to their pre-injury level at 1 year. I would say that people are probably closer to that, maybe around the 2-year mark. And obviously it depends on each patient and how much rehab they're doing and how committed they are to that rehab, because it's actually a ton of work. But this is sort of our general plan that we go by. So in the first 3 weeks, especially the first week, it's a lot of rest. It's a lot of rest, and then you're working on knee motion, with the biggest one being getting that knee straight. The knee likes to sit in a bent position, as you all know, and so getting it nice and straight is super important. And then working on that quads activation like we were chatting about before, because it totally goes to sleep after surgery, and getting it activated is really helpful for the future. After that, you really start your strengthening program. You have to go through phases, and we give you the whole protocol when you come for your surgery. You can also find it on the Banff Sports Medicine website, but basically you have to meet the phases goals before progressing on to the next one. And we don't let you jump to the 1-year mark at the 3-month mark. Like, that's impossible. You can't do that. That's not really good for anybody. But we do let you progress at your own pace, which is going to be best for everybody at the end of the day. Between the 3 and 6 month mark, you're really progressing your strengthening, and some patients are going to start some jumping prior to the 6 month mark, which is great, because at that 6 month mark, we do functional testing with the patients. And so that's a series of exercises where there's single leg hops, hopping for distance, hopping for time, different things that help us and the physios decide where the patients are at in terms of their rehab, whether or not they're on track, how we can help try to modify some of the exercises that they're doing, and giving them guidance for the next 6 months. And so then in those next 6 months, they can start progressing through those phases even further, but they can start adding in some sports specific drills. That does not mean that they can start scrimmaging. We don't want patients going back to sport until the 1-year mark. And they should, but they can definitely be working on drills. So if you're a soccer player, you can start passing, you can start some dribbling, but in a very controlled setting, not where adrenaline is running high and patients or players want to get back. They're all eager to get back, and sometimes we have to hold them back a little bit so that they're not going to re-injure that knee. And then at that 1-year mark, that's when we let them go back to sport, assuming everything is going well and the surgeon is happy with progress. So I think return to sport is a really big one, and people always want to know if they're going to return to sport. And obviously that's our goal. That's the patient's goal, that's the athlete's goal, that's the coach's goal, it's the physio's goal. We're all on the same page for that. Unfortunately, there is about a 30% chance of either re-injury to the same knee or the contralateral side. This is specifically true when we go back to sport under rehabbed. And so one of the things that I think people forget is that not only is there an ACL tear, and do you lose muscle on that injured side, but the other side can also take a bit of a beating. And so if you haven't been doing those sport-specific drills between the 6 month and 1 year mark, the other side isn't ready either. And so you don't have the same ability to do this activities and the drills and the game that you were doing prior to your injury. Just nothing is there. Your brain is not sending the same signals that it used to either. And so you need to rebuild all that. And that's why doing those drills are so important, so that you build up your contralateral side as well. And you're retraining the injured side to do those motions, to do those activities, and in a very appropriate way, in a well, with good technique, so that they're not going to be at high risk of injuring their knee in the future. And then so the next thing is always, well, how do we prevent these tears? If they're so common and they take athletes out of sport for at least a year, how can we prevent it? Well, that's a good question. And I think it's hard to ever really prevent it 100%. But obviously starting off with appropriate activation and stretching before your activities. If you go into your sport and you haven't warmed up, your muscles, your ligaments, everything are just tight. And so, doing appropriate activation stretches are always going to be beneficial. And then we always talk about strengthening, which is obviously important, but I also think balance of muscles is really important. So not just having super strong quads or super strong hamstrings, but also focusing on your glutes, focusing on your core. So if you look at the picture on the left, you have two girls that are doing squats, and you have one on the left whose hips are nice and horizontal to the floor. There's no valgus, or what we call, valgus thrust of the knee, where the knee is jutting inwards. Whereas on the right, you see the hips are not level. She's allowing her hip to drop, and that knee is really kicking into the inside. That's the type of pattern that can lead to that ACL tear. And this is more common in women than it is in men to have this type of a position. But it doesn't mean that men also can't be at fault for having this type of valgus position. So learning appropriate jumping mechanics is super helpful, because again, like we saw with that basketball player, when he landed, this is the position that he probably landed in. And so if we can be following our athletes and coaching our athletes to try to land in a more appropriate position, or take off in an appropriate position, that will be helpful for them in the long run. And I really think that having either a coach, an athletic trainer, or a physio, someone who can watch you do these exercises, making sure that you are doing them appropriately and understanding what you're supposed to do, can help in the long run. Okay, before I go on to patellar instability, are there any questions?
Feel free to type in the chat too if you have a question, and I can ask it. Was that someone, sorry, that had a question?
Yeah, I do. Sorry, can you hear me?
Yeah, go for it.
Hey, my big problem is how to rule in or out the non-operative management of ACL tears, or these gray area patients that may be unstable, but your hope can be copers. Is there any kind of tricks to making that a better decision than, rather than my format right now is the planned failure of a certain number of patients in physio and having to go on to surgery?
Yeah, absolutely. So when it comes to like a pediatric population, so a younger population, I think non-operative treatment is very rare. It would be more in someone who is not athletically inclined, someone who doesn't want to do sports, and someone who maybe doesn't have that loose of a knee. The biggest distinguishing factor for us, let's say in an adult population who comes in and we know they have an ACL tear, they've had an MRI, the MRI says it's a full grade tear, and then we examine them and they have, let's say, like a 1 Lockman, but they don't have a pivot. And that makes me start thinking, your ACL might have actually scarred down and you might actually be able to cope. There might be enough healing potential in that ACL where it's scarred down that you might not need surgery. So I would say the biggest distinguishing factor are probably twofold. One is your history. Do they notice any instability on a regular basis? Patients who are telling me that their knees giving way with activities of daily living is a red flag, and I think immediately about surgery, because it means that they're having those instability episodes on a regular basis and are doing more and more damage to their cartilage and their menisci. Whereas someone who says, yeah, my knee doesn't feel unstable at all, like, you know, I've gone back to sport and I haven't noticed anything, and then I examine them and they don't have a pivot, but they do have some A to P, increased A to P translation. That's someone who I think, you might do okay with the brace and you might do okay with non-operative treatment. But it is a bit of a discussion with the patient. To be honest, we always talk with them with both options. And sometimes the patient actually dictates it for us and they say, you know what, I've thought about it. I've talked to lots of people. I just want surgery. And then there's other people that are like, yeah, I'm pretty happy with my knee. And I've actually been able to do stuff already. And I don't want to take the risks of surgery. At no point are they ever fully excluded from surgery, so they could come back at any time and they could change their mind. But that's kind of how we make our decision. Does that answer your question?
Yeah, perfect. Actually, really good.
We also
Any
have
other questions?
Yeah, a question that came up over the chat from Alan. So the question is, as a soccer coach, any wisdom to starting the season with running shoes versus cleats to reduce potential twisting to knee? I have thought this because the cleat really plants the foot until more early season training complete.
Ooh, I don't know that I'm the expert on shoe wear. The only thing I can think of about not wearing cleats is that often in the early season, there's a lot of mud and it's slippery, and I worry about other type of injuries, even ACL injuries, with slipping, because you could fall backwards pretty easily, and I think that would be my other concern. So I don't know that one is necessarily better than the other, to be honest. You would probably know better than I would. Any other questions? Okay, how about we move on to some patellar instability, and if you guys think of other stuff, feel free to ask at any point. So again, I'm going to just start off with a bit of epidemiology. So patellar instability is relatively common, an incidence of about 7 in 100,000. And this definitely increases as the population is younger. So up to about 43 per 100,000 in a younger population. We actually often see patients coming in with their first instability episode around the age of 13. So it's quite young. And then there's a ton of patients who have ongoing instability or pain. And then the recurrence of it after a first-time dislocation is anywhere between 15 to 44%. And the reason why that number is so varied is that each patient that comes in with patellar instability is not just patellar instability. It's not just one diagnosis. There's a ton of different factors that contribute to that instability of the kneecap that make it very complicated. And so these numbers can vary quite a bit. And so that leads me to my next part is, well, what is patellar instability? And I think it's an important thing to try to define because, you know, it's not just a kneecap dislocation. It's not just those patients that come in and say, yeah, my kneecap dislocated and someone had to put it back in. That's not what patellar instability only is. It's part of it, but it's not the only thing. There's lots of patients that come in and say, you know, my kneecap feels unstable. I feel like it's going out, but I've never had a full dislocation. That's also part of patellar instability. And so there's multiple different factors that lead to this instability that makes it a lot harder to diagnose and a lot harder to define compared to, let's say, an ACL tear. So again, just a little bit of anatomy. And, you know, when it comes to anatomy for patellar instability, like I was saying, because it's so multifactorial, it's not just one ligament. It's not just one structure in the knee that leads to that instability. So the main thing that people think about when they think about patellar instability is that MPFL ligament. So the medial patellofemoral ligament. It's a structure that originates on the patella and then goes and inserts on the femur. And it helps to prevent lateral displacement of that patella. And when that patella goes out, it most frequently wants to go out laterally. It's very rare for it to want to go out medially, even though sometimes patients come in and say, I am 100% sure my kneecap went medially. But what they're seeing is actually the medial femoral condyle while that patella is out. That's what they're seeing, that like round structure that they think is their patella that's gone out medially. Other things that are super important when it comes to patellar instability is looking at different type of structures around the knee. So one thing is looking at the height of the patella. So is the patella high or low in relation to where we think it should be? And the reason why that's important is that if a patella is really high, it's not actually articulating or making contact with the groove of the femur, or what we call the trochlea. And if it's not making contact with that trochlea, then it's not getting the stability that it wants or that it needs as the knee goes into flexion. And then the other thing, one of the other things that we look at is something called the trochlear groove and, or what we call the TTTG. So the trochlear groove and the tibial tubercle. And basically what that is a relationship between that groove of the femur and where the tibial tubercle lies on the tibia. So that's that nubbin of bone that's a little bit more prominent around the knee joint on the tibia. And that gives us some information about how much that kneecap is trying to be pulled out to the outside of the leg, so out laterally. And then also we look at the trochlea itself. There's some people who have what we call a deficient trochlea. So it's not very deep, it's not very pronounced. And so if it's more of just a flat structure, again, as the knee goes into flexion, that kneecap is not able to sit anywhere. And so it has more ability to move laterally because there's no groove for it to sit in. And then we look at, what we call femoral anteversion, which is just twisting or rotation of the femur or rotation of the tibia. And all those things together can lead to this patellar instability. And it can be very difficult to figure out what's causing the patellar instability in any given patient. So again, we look at mechanism of injury. And so like I was saying before, when it comes to ACLs, it's much more standard to get a typical story, some type of pivoting injury. They often feel that pop, that swelling. But when it comes to patellar instability, it's not near as straightforward. Definitely, it's most common to have a patellar dislocation when the knee is fully extended, because again, like I was saying, that patella is not engaged in the trochlea, in that groove of the femur where it's more stable. So in that fully extended period position, the kneecap can go out laterally. So that's definitely the most common one. And then the other thing that we do often see is some type of contact. So this you could see more in football or rugby, where there's contact sports and someone gets a direct blow to the knee and the kneecap pops out. So if we go over typical symptoms again, pretty similar in many ways to the ACL, pain, swelling, and then the other thing is looking down and seeing that your kneecap is out to the outside. And so here you can see that the kneecap is out to the outside, and patients will look down and see that. And we often ask them if they have ever seen that. It just helps us to confirm that a full dislocation has happened in the past. And then the other thing that they often have, like I said, is the swelling. And swelling can again be multifactorial, but one of the things that we don't want to miss when it comes to a patellar dislocation with a ton of swelling or a big hemarthrosis is that they haven't done damage to the cartilage of either the femoral condyle or the patella, because sometimes they can rip off a big chunk of bone, which is what we call an osteochondral fracture, and that has to be fixed acutely. It shouldn't be left alone. It shouldn't just be left to float in the knee, because it can often be a pretty big chunk that if it doesn't get addressed immediately or very soon, it's never going to go back. And then during recovery, the symptoms that people have is just that their kneecap feels unstable. It feels like it's always wanting to go out. But again, the stories that people tell are not always as consistent as you would like them to be. So in terms of initial treatment, so again, coaches, athletic therapists, or physios who are on the field with them, the most important thing is if you do have a true dislocation is trying to get that kneecap back in as soon as possible. This can even be done on the field if you're comfortable with it, but the easiest position to do that in is try to get the knee out into full extension, and then it can come back in a lot easier. You can't really reduce the patella when the knee is flexed. It's just not going to go. All the structures are too tight, and so you need to get that knee out straight before being able to put it back in. In some cases, the patient has to go to the emergency department and get some sedation before it's able to go back in. And then from there, it's pretty similar to the ACL. So working on that RICE protocol, making sure you're getting good range of motion, you're getting rid of your swelling, and specifically with patellar instability is working on that VMO, so that vastus medialis muscle, trying to strengthen it, because a lot of patients with patellar instability are just lacking in that muscle. They have much more defined lateral muscle, but their medial side is weak and it's not able to help keep that patella on the medial side. The lateral side is too strong and pulling that patella out laterally. So working on that muscle is important. Unfortunately, it's very difficult to develop. There almost seems to be a developmental or a congenital component to it that prevents them from getting super strong muscles. That being said, the patients who have more of a contact type injury, they actually tend to have pretty good muscles, and they tend to be a little bit of a different kettle of fish than those who have your chronic type patellar instability. Those are the ones that we see who have more atrophy of that VMO. And then the next thing you know is getting your referral to your sports med doc, and then possibly getting a referral to the orthopedic surgeon. So again, when it comes to diagnosis, we always start with our history and physical. And like I've stressed multiple times, the history on this is not as clear. And so that usually requires a little bit more digging before we're able to figure out what exactly is going on. The other thing to always ask about is whether or not they are like super stretchy people. So there are certain conditions like Ehlers-Danlos syndrome that can lead to much easier dislocation. So their body structures, their ligaments in general, are just so much looser than a normal structure in people who do not have Ehlers-Danlos syndrome. And so they are people that we take extra precautions for, because we know that their risk of redislocation or re-injury even after surgery is much higher than normal. And then in terms of physical exam, you know, it's very similar again to the ACL. We're looking at that muscle bulk, specifically that VMO, and then we're looking at apprehension. So what is apprehension? It's a good question. So basically what you're trying to do is see whether or not the patient is uncomfortable when you're starting to push that patella out laterally. And so this is done at 0 and at 30 degrees. At 0 degrees, like I was saying before, that patella is not engaged in the trochlea. So there's no bony structure to help keep that patella engaged. And so you can see if they have apprehension, and they often do. Then you want to do it again at 30, because at that point, the patella should be engaged in the trochlea and the bony structure should be giving some stability. So you should have much less lateral instability at that point. The one time that they don't have that, or two of the times that they don't have that, is when they do not have an appropriate trochlea. So their groove is not well defined and it's much flatter. And so they can still have lateral translation of that patella, or if they have patella alta, which means that they have a high riding patella. And so at 30 degrees, they're not actually engaging the groove yet, because their patella is still floating above the groove. And so you might still have some lateral translation at that point. And then the last thing is the J sign. And so I want to see if this works. Yes. Okay. So this is a J sign, and a pretty good one. So you see the kneecap is going straight up and then it kicks out laterally. And so that's what we call the J sign. So that's one of the things that we look for on our exams. In terms of diagnosis, so it's a little bit more complicated when it comes to patellar instability compared to ACLs. You know, we get an X-ray for ACLs for sure, and then sometimes we get an MRI. But when it comes to patellar instability, every single patient gets X-rays for sure. There's a bunch of things that we look on for X-rays, and then everyone gets either a CT or an MRI. The reason why we're getting at CT scan is we want to look at some of the bony anatomy. So one, we can have a look at the trochlea. So this is that groove that we were chatting about here. This is a CT scan, and it's what we call an axial view. So if you imagine that someone is lying down and you're looking from the bottom up, so like their feet up to their head, this is a cut through the knee. This is the front, so this is their kneecap, and this is their femur. This is the back of the femur, and this is the front. So this is their trochlea, the little groove. And as we scroll through the images, we can get a better understanding of how deep or shallow that groove is, or how what we call dysplastic, which basically means that it's not normal. We get a better idea of what that groove is. We can also look at how much tilt there is in the patella. So the patella, it gets tilted over laterally, so to the outside, and that's because of much tighter structures on the outside of the knee. And that gives us an idea of whether or not we have to release some of those structures to let that kneecap sit back in the groove. And then the other thing we look at with the CT scan is that TTTG number that I was talking to you guys about. And so you're measuring a distance between the tibial tubercle, which is, this is just an overlying image of what the tibia would look like. And this would be the tibial tubercle here. So measuring a distance between there and your groove. And if it's high enough, then we actually go and cut that little bit of tibial tubercle nubbin off, and we move it over medially to get rid of that lateral pull. And basically, a lot of the surgery that we do is to get rid of that lateral pull to bring it back more in line so that we have proper tracking of the patella in the groove. The MRI is also useful for us, more useful when we're concerned about an osteochondral fracture. So if that patella has, when it dislocated, it knocked off a big piece of bone with cartilage, or just cartilage, because if it's just cartilage, then we actually can't see it on x-ray. If there's bone associated with it, then we do see it on x-ray, but this gives us a much better idea of how big it is, where it came from, and if there's any other injuries in the knee. But it's not imperative to get an MRI for every single patellar dislocation, unless you have a big hunch that they might have done more damage to it. So like very large hemarthrosis, then getting an MRI is a good idea. In terms of treatment, so our usual algorithm is if you've had 2 or more dislocations, then you are candidate for surgery. That being said, like I said before, not every single patient has a full dislocation. So you'd be excluding a ton of patients who are actually quite eligible for surgery. So that's where the second part of the eligible criteria comes in, where those who are no longer functioning due to their patellar instability. And that could be people who are just having chronic instability of their patella, where it's not fully going out, but it's going out enough that it's causing pain, and they're not able to do the activities that they want to be doing. And so those patients are also surgical candidates. In terms of treatment, so like I was saying, there's just so many different anatomic components to patellar instability that it's not just one surgery for all patients. There's a variety of different surgeries that we can do, and it totally depends on how the patient presents, what their anatomy is, and what's contributing to their patellar instability. The one thing that every patient gets is an MPFL reconstruction. So that's that ligament that we were chatting about before that originates on the patella and then inserts onto the femur. And so in order to do that, we usually take just one of the tendons of the hamstring, so a little incision on the front of the knee, and we take one of the tendons and we reconstruct a ligament. So this is what that ligament would look like. We then plug it into the patella, and it's a broad insertion on the proximal third of the patella. That's where we insert it. And then we plug it into the femur between the adductor tubercle and the medial epicondyle. And that's where the MPFL wants to live on a normal basis. That's its anatomic position. So everybody gets one of those procedures. In terms of the other procedures, so whether or not we release the outside structures of the knee, or whether or not we cut that nubbin of bone, the tibial tubercle, and move it over, or if we actually go to deepen the groove of the trochlea, that all depends on the patient, whether or not it's indicated or not. And there's different things that we look at to make those decisions. I wish that there was a really straightforward algorithm that we could just follow, but unfortunately there's not. It's actually pretty complicated in terms of the thought process. One, they need to have the anatomic problem to deal with it. And two, that they need to be of the right age. They need to be doing Like we have to look at their function and everything else. There's lots of different factors that come into that decision making, which makes it hard for the surgeon and for the learner trying to figure out which surgeries to do. And then in terms of rehab, so very similar to ACL in terms of our actual protocol. The biggest differences are one, post-operatively patellar instability patients get a brace. So it's a hinged knee brace. They're still able to be weight bearing as tolerated. They're still able to do range of motion as tolerated, but we brace the leg because of the quads inhibition. They just have so much more quads inhibition than the ACLs, and it takes so much longer for them to get it back. The other thing that we notice with these patellar instability patients is that their recovery tends to be longer. So today we saw a patient at 6 months who was an MPFL with a tibial tubercle osteotomy. And she was the only patellar instability patient we saw today compared to all the ACLs that were also at 6 months. And the ACLs, you know, there's a little bit of variation between all of them, but they're all doing pretty well. Whereas the MPFLs, they take longer to get better. And I think a big part of it is that a lot of these patients have been living with patellar instability for years upon years, and they have to retrain their brains to think that, okay, I can trust my knee. Because we were testing her today and her kneecap, she's like, no, I really don't feel like it's going to go out. I'm not worried that it's going to dislocate, but she had to retrain her brain to believe that. She couldn't quite believe that her knee was stable because they had lived with it for so long. And I think that's a really hard part of the patient recovery that we don't talk about enough. And then in terms of return to sport, again, it's super variable. I find the ACLs, especially in the young population, like we were saying before, tend to be a very athletic group, whereas the patellar instability patients are a little bit more variable. You certainly do get those patients who are super athletic, and I think that those are often the patients who have more of that acute, you know, full out dislocation. It's been the first time they, you know, they might be a teen, they might be their young 20s. But really the only problem is that they dislocated their patella. In contrast, you have the patients who have, you know, not a normal trochlea, they have rotational problems, their patella is just unstable, but it's never fully dislocated. Those are patients who might not have actually really gotten into sport in the first place because they've been dealing with this the time they were 12, 13, when they should be getting into sports in the first place. And they just never really felt comfortable because their knee, they couldn't trust it and it was painful. And so this is a little bit harder to say who returns to the same level of sport because I think the population who has patellar instability is just so much more varied. The one thing I think is important though, and I wish we had more of it, is that some of these patients probably need to be working with a sports psychologist, like I was saying before, or having just a really good coach, athletic therapist, or physio who can work with them and really get them to learn to trust their knee again. But I think it takes a lot of diligent time and effort, both on the patient's part and the coach or physio or whoever's working with them. It's not an easy road and it definitely takes time. And that's all I got for you. So if you have any questions, I'd be happy to answer them.
We have a question on the chat from Stan, and he's asking what brand and type of brace for patellar instabilities do you recommend?
So the bracing that people tend to use is some type of patellar sleeve brace. I'm trying to remember what Dr. Heemstra likes to use because she has one brand that she does like, but I can't remember it off the top of my head, to be honest. I can ask her though, and we can get back to you.
Dynatrack patella stabilizer. Does that sound familiar?
Yep, that could be it. I know, I think she's got like two that she likes. I'm totally blanking on what the names are right now.
Dr. Heemstra is on the call. I don't know if you are listening right now, if you could jump on an answer. Breg.
Breg, that's it.
Breg, so
Thanks,
thanks, Sarah. We have another question from Fabi on the chat. She's asking, is a TTT ever done in isolation?
I would say no. I know that they used to do that for sure. We've definitely seen patients come back with it, but now the standard would be to do the MPFL plus a TTO. That MPFL still needs to be reconstructed to provide more support on the medial side of the knee, and then the TTO would be in addition, if warranted. And even in a revision situation, let's say the patient had previously had an MPFL reconstruction, but no tibial tubercle osteotomy. In the revision situation, if now they were saying, you know what, you do have a reason to do that TTO, then we'll do a revision MPFL with the TTO.
Another question from Fabi. Any differences in the MPFL with TT rehab versus MPFL on its own?
Yeah, so the biggest difference, and this is a little bit surgeon dependent, I know Dr. Kopka and Dr. Heemstra do it slightly differently, but the brace will get locked. So Dr. Heemstra will lock the brace for 3 weeks and then reevaluate in clinic, whereas Dr. Kopka will probably only lock it for a couple days to a week. But in both situations, the patient is still weight bearing as tolerated. And then once we let them start ranging their knee, it's a very similar protocol. The difference is that the patient is in more pain. They've had more surgery, it's a bigger surgery. And so that definitely causes more discomfort for them in the long run. And it's just a bit of a slower recovery.
Another question. So I think this is from Barb saying that a previous talk that about 25 to 30% of the ACLs also had concurrent patellar dislocations. Are you still seeing that? Some of these showing up later.
Oh, I have not seen 20 to 30% with concomitant patellar instability with the ACLs. I think that number is a little bit high. That would be my feeling. I don't know what the literature is on it, but that seems high to me.
Hi, I have a question, if that's okay. Great talk,
Yeah, absolutely.
Dr. Marien. Thanks very much. I'm not sure if I missed, but did you go over your rehab protocol for a first-time dislocator for patellar instability?
I didn't actually. The main thing when it comes to first-time dislocators are regaining that range of motion, regaining any type of quad strength that they possibly can, and building up any quads that they were lacking before. And I think the other thing to always remember, and again, the physios are great at this, but is remembering that it's not just the knee, it's not just the knee muscles, it's also the glutes, it's the core. And if those muscles are not strong, then the knee can't be strong. And so focusing on the whole body rather than just focusing on the knee is super important. We do recommend a patellar stabilizing brace if they feel like they need it. But they can wean out of that as soon as they're starting to feel more comfortable. And really at the end of the day, it's building up that strength to be able to try to keep the kneecap more balanced with the VMO firing and a little bit less lateral firing of the muscles. So a little bit more balance in terms of the muscles around the knee.
Great, thank you.
Just a comment, I think, from Sarah saying that we published a case series of 22 combined ACL plus MPFL, and now have around 30 of these cases that were symptomatic and needed both ligaments reconstructed.
Right, that makes sense. I just don't think it's up to 30%. That's what I was not sure about. Sarah would know way better than I would, though. She definitely has that data. Okay, it seems like there are not any more questions, so I will let you all go, but thank you very much for your time and thanks for joining us.
And thanks everyone for your questions as well. And thank you, Dr. Marien, for putting this on. It was a great talk.